Good morning in Spain, good afternoon in Abu Dhabi. It is a pleasure to introduce Mexican Emre Simsekler. The first, initially he would be here. In fact, he has a ticket flight, but finally due to some family constraint, Emre will have the talk in online. And Dr. Simsekler is a research professor and acting chair of the Department of Management Science and Engineering at Khalifa University of Science and Technology. He earned his PhD from the University of Cambridge, and during which he was visiting the research, research at the Center for Medical Innovation System at the University of Tokyo and the Center for Patient Safety and Quality Research at Boston Children's Hospital. He holds visiting fellow appointment at Boston Children's Hospital, University College London, School of Management, and ADIA Lab. His research is focusing health system, and he has long experience and a high quality research in the connection between humans and artificial intelligence, human decision making, human-centered digital technology, and he is developing now a very interesting research application in this area. Really, it is a pleasure, Emre, to meet you online. Sorry. I hope we will meet again face-to-face in Abu Dhabi. And really, I am sure that all the students will enjoy with your talk. Thanks. Please.
All right. Thank you very much, Professor Paco. I wish I was there with you guys. Thank you very much for the invitation once again, Professor Paco. I really wanted to be there, but due to some family constraints, I couldn't make it. But hopefully next time we can meet in person with you all. Just to confirm, you guys are able to hear me, right? Students, if you are able to hear me, can you clap once? All right, perfect. Unfortunately, I cannot really hear you, but this is our communication from now on. All right. So I can see that you are at least clapping, but I cannot hear you very well. All right. So as you can see from the title, Engineering Safer Care, a Systems Thinking Perspective in AI-Driven Digital Transformation. Professor Paco already provided some introduction about myself, my background. But just to give you a little bit introduction about myself, I'm Emre. I am an associate professor and acting chair in the Department of Management Science and Engineering at Khalifa University. Khalifa University is one of the research intense universities in UAE, in Abu Dhabi. So if you have never visited, you are very welcome your next time. I had my PhD from the University of Cambridge. Since then, I've been working in health systems design related research area. I am not alone in my research. I have a research group, and these are the current research team that I have. And I would like to also acknowledge my funders, supporters who supported my research. Okay, so my research is all about healthcare. All right, and since I find someone like you guys, great minds, I would like to discuss the topic. And at the end, if you have any questions, if you have any ideas to improve the situation, I would really like to hear from you. All right. But let's start with one quick question. So if you could choose just one principle to guide every clinical decision, what would it be? Unfortunately, I cannot hear you, but think about, what could be the single most important ethical principle in healthcare? Or when everything is at stake, which ethical principle matters most? Or at the core of healthcare, what principle must never be compromised? Actually, this question was asked thousands of years ago, and the Hippocrates that time gave an answer saying, first, do no harm. So every day, millions of people are treated safely and successfully in healthcare organizations globally, right? But still, there is a growing awareness that medical errors harming thousands of people around the world every year. Just to give you an idea about the magnitude of the issue, It is the leading cause of preventable harm and death worldwide. I'm talking about the medical errors. Increased healthcare costs through extended length of stays and additional treatments. And it has a huge contribution to the clinician burnout and moral distress. To give you some figures from the US, it is the third leading cause of death following heart disease and cancer. So think about the magnitude of this issue. Like there are huge number of medical errors are happening in healthcare organizations. Now, the question that we can really ask why this is happening, why many health errors are happening in hospitals. First of all, we need to understand the patient provider communication, right? I mean, at the end of the, in the sharp end, maybe we see patient provider communication. But one thing that we really need to understand, the patient is not treated by only the provider, right? Actually, in this process, the patient is treated by the whole system, which includes tools, technologies, team, training, culture. Everything has an impact on the treatment process. And if the system or the process is poorly designed, then we end up with a human error. So human error is just a symptom that we see at the end. But most of the time, these errors are reasons of the poorly designed systems. So what are we trying to do now? I mean, I think in the last 2 weeks almost, I think tomorrow is the last day, you've been seeing a lot of, initiatives about the use of AI, right? So what we really imagine with AI, as I call it work as imagined, we are hoping that AI will come to the system and it will be embedded into the care delivery. It will enhance safety, streamline workflows, and improve decision making, right? So this is the ideal scenario that we are expecting. But as a system design researcher, one thing that I always need to pay attention, what if something goes wrong? And I call it work as not imagined. Because as we can say to err is human, we can make errors. We also need to accept the fact that AI can make errors as well, right? And here there are a lot of discussions happening, how we can make AI safe. And this is exactly what I am focusing in my research. And one particular challenge right now with the use of AI is insufficient governance, right? I mean, if we don't have a very particular governance, applicable to the particular healthcare organization, particular community, then we might end up with some errors in the process. But one thing that we really need to understand when we call AI safety, this has an implication to patient safety as well. And here I would like to make one definition that as much as safe AI we are expecting, that will have implication to AI for safety. And imagine like a complex and dynamic system like healthcare, all these risks are interrelated. For example, technology risks, then we can talk about AI, includes machines, hardware, devices, tools, techniques, systems, and methods of organization may go wrong. Ultimately, this might have an impact on the patient safety, right? We can end up with some clinical risks. And I do believe that we really need to understand the trade-off between this. So when we start implementing AI, what is the implication to the safety, particularly patient safety and provider safety? So for this, we need to really have a holistic understanding. But what is the current practice, at least in the research? So maybe you've been hearing a lot of technological, focus in AI, right? The current focus in AI is on technology, often framing it in opposition to humans. So there's a huge discussion, particularly in healthcare, whether AI will come and replace doctors, replace surgeons, replace nurses, right? I think it is the right time that we need to shift from this technological centric view to a systems perspective to really increase the success rate of AI adoption. And this, simply speaking, requires designing AI with human system interaction in mind from the start. This is very important that I say human, inclusion from the start, because in general, what happens when it comes to adoption, we include human at the end, and this is the main reason why the AI solutions are useless. I'm sharing one commentary here. I mean, even the title says everything. All models are wrong and yours are useless, making clinical prediction models impactful for patients. I think this is the key, right? I mean, how we can make the AI models impactful for the end users. And to make it real, we need to have a, um, good collaboration with the clinical stakeholders like doctors, nurses, who can really understand what we try to do. And they should also let us know what are the needs and their requirements. All right. So how we can achieve this, like how we can have a system level safe AI design and adoption. So here three components are very important to note. Technology. I think this is the main focus right now in AI, and healthcare is not an exception. So in healthcare, the focus is also in technology at the moment because we are still in the AI development phase. But when we move to the operations and deployment of AI in healthcare practice, in real practice, then we need to really understand the implication of operations as well as human. But one thing that is also very important here, policy. So we need to also understand what is the role of policymakers in AI development plus deployment. Okay. So how we can ensure that AI will be successfully implemented? So we need to have a good understanding of system, and this is my main expertise, and this is what I really want to implement with the AI adoption in healthcare organizations, particularly. So just to give you a quick introduction, what we really mean by system, particularly dynamic complex systems like healthcare, we have integrated set of elements with a purpose, right? I mean, in healthcare, this purpose is to treat patients safely and successfully. And we have four perspectives that we need to have a really good understanding. And I would like you to remember this because at the end of the presentation, I will have a very quick asynchronous workshop, very quick one. So I would really like you to remember these four perspectives. So people. So first of all, we need to understand the interaction among people, like when AI comes into the picture, how it will affect, for instance, patient provider communication or provider to provider communication, physician to nurse, nurse to surgeon. So we need to understand how the interaction will change. And risk, usually speaking, I mean, in healthcare applications, when we look at it, I mean, I'm going to talk about it shortly. The main application area is risk management, right? So we have clinical risks, we have clinical challenges, and we try to predict and assess and manage them, right? So here it is very important to understand if we adopt AI, what could go wrong, right? So proactively identify those things. And when we say design, design is always about, understanding what is the right problem, what are the user needs, and how we can capture their requirements. Okay. So at the end, again, you will see the hammer nail example that I will give. Sometimes AI is not the solution, So yes, AI is not just a buzzword in healthcare. Certainly, it will find a place, a substantial place. But we really need to understand whether AI is solving the right problem. And the system is understanding complex and certain real world problems that involve highly interconnected technical and social elements. We need to understand the healthcare is sociotechnical system. That means it brings human and technology together, right? It's a dynamic, complex system, and we really need to understand the interrelatedness between all these components. All right. So if I bring this four perspective again in healthcare, these are some of the components that we really need to pay attention. And there are three examples that I would like to give. Safe AI governance, which provides clear oversight, ethical standards, and compliance framework to guide safe and trustworthy AI adoption. Because without governance, we cannot talk about application in real practice, right? Then the second one, which I believe really important, proactive risk management practice and culture. So I'll talk about this very briefly. What I really mean by practice and what I mean by culture. And the third one, which is really very important, and I appreciate that Professor Paco is with us. He is leading the way, in this particular field, like how we can understand, and explore opportunities to augment AI with human intelligence and human-centered design. So let's go through these three, components one by one. So this is a very recent, paper that I had. I mean, this figure that you see is from there. We try to explain here in this paper what are the main aspects that we need to pay attention, when we talk about safe AI governance. And these are not only for the AI development, but think about these are important components for AI deployment in real practice. Because as soon as we have the successful AI algorithms, tools, that the next step for us will be the deployment, right? And we don't want to delay that process. Or, as I mentioned at the beginning, we want AI to be safe from the beginning, not at the end. The first item is technology fit assessment. So we need to understand, the technology that we are trying to implement, deploy, is fitting to the current practice in hospital settings, right? Then the second point is the implementation. We need to understand how the AI solution will be integrated into the current workflow, right? I mean, there is a practice already in the hospital, and we need to understand if AI comes to the picture, how it will affect the practice. Okay, this affect most of the time at the beginning negative, right? I mean, whenever we brought a new technology, because we need to train people, we need to provide guidance, we need to provide X, Y, Z, a lot of things. But we really need to ensure that this will not compromise patient and provider safety. And the third one is continuous monitoring. So we need to have ongoing safety, accuracy, fairness, and regulatory checks to ensure that the AI algorithm that we develop is working in long term. All right. So if we do not do any of this, or if we miss any point here, I would like to emphasize this one that I really like, coming from the accident models in other safety critical industries. Have you heard about Swiss cheese model, guys? Clap once if you heard about it. Okay, so Swiss cheese model is an incident accident model actually developed by James Reason long time ago. But now we try to see how we can incorporate this into healthcare, all right? And the challenges like accidents, incidents do not happen because of a single failure, right? In fact, most of the time, these errors are in the same, holes, I mean, in the same layer, as you can see here in this example. And then we ultimately end up with, with an error, incident, accident that is affecting patients and provider. But four things that are very important here. We need to have a good understanding of governance and policy, like what is the data privacy, security, bias, fairness, accountability, regulation. Then model development. Again, this is the main focus right now in AI in healthcare. So we pay more attention to this part, like data access, pre-processing, algorithm design, innovation, ethical experimentation. Then model training evaluation, and ultimately, which I am more interested in, deployment and operation. So system integration, staff adoption, trust, reliability, and maintenance. So this is very important to understand, what are the components that we need to pay attention to not make, any errors that will have some implications to patient safety or provider safety. So this is safe AI governance. The second point that I would like to pay attention is the proactive risk management practice. Most of the AI solutions in healthcare are just about to predict what will happen, right? I mean, whether patient will be, have a cancer, diabetes, or some operational predictions as well, and which is typical risk management exercise for us. But here, one thing that is really important for us, what we really benefit with the use of AI, or another question that I have here, can AI help us respond to all these questions in a proactive manner. For example, what is going on, right? I mean, in the current practice, what could go wrong, particularly in terms of patient safety or provider safety, and how can we make it better? So this is a very important challenge in healthcare AI applications. So we really show the prediction results, but we are unable to come up with really good, successful interventions. So we need to provide management pipeline, right? Risk management system, not only prediction of the outcome for a patient, but also what is next? What is the intervention that we recommend or AI is recommending? Here, one another thing that is very important that I really like to emphasize. AI should also help us identify something that we don't know, or we know that we don't know. I mean, there is an analogy. I don't know if you heard this, if you're interested in risk management. And actually, this comes from one politician statement from the US, Donald Rumsfeld, if you know the guy. He says that there are something that we know, right? And some known unknowns, we call it, that we know that we don't know, right? I mean, when we look at the AI in future, I mean, we say it will disrupt everything, but we don't know what will be the implication. But there are also unknown unknowns that we don't know, right? So in long term, we don't really know what could be the implication of AI in healthcare practice. All right, solutions, let's say in short term is good, but long-term impact that we need to really understand. And this is one of my main discussions with the healthcare organizations and healthcare providers as well. So they say, for example, just to give you an idea, that's okay. As providers, we can make mistakes, we can make errors, but we learn from our experiences. We learn from, those mistakes that we do, right? And AI can, in long term, decrease their imagination, stimulation of new cases, new processes, new challenges. So that's why we really need to understand how AI is supporting us throughout this process. And when it comes to integration, there is one another element that I would like to really emphasize, which is proactive risk management culture. I don't know if you paid attention to this, term before. Maybe you've heard safety culture or risk culture, but again, with the AI, our main ultimate expectation is to be more predictive, more proactive, right? But think about healthcare. When I say healthcare, it is actually not correct, right? Healthcare is sick care. So in general, we go to the hospitals when we become sick, right? I mean, so this is something that we really need to understand whether the culture in hospital is ready to be proactive or is ready to be predictive. So there are different frameworks available in the literature. This is one of them from the Manchester Patient Safety Framework. So my research shows that hospitals in general are reactive or bureaucratic, meaning that they do something when there is an accident. This is what happens most of the time. Or they have systems in place to manage all identified risks, but their system is not working very well. Okay? And with the AI, we try to reach to this too, right? Like how we can become more proactive and even more generative, meaning that the risk management, let's say with the use of AI, it will be an integral part of everything that we do in the hospital. Okay. And this will be resonating the idea of AI native systems, right? Like everybody knows the AI, how it works, and it is embedded in the practice. But if the hospital is not ready for this, the risk culture and the AI strategy is, I think you can see in the picture, that is very important. And there is one a quote, very famous one. Culture eats strategy for breakfast. I don't know if you heard it before. But without culture available in the practice, in the hospital, in the health system, we cannot expect any benefit from the technology that we have. All right, so it is really important to understand the hospital culture or the practice in the hospital is ready to, implement such proactive or preventive technologies. Okay. Let me give you one example about this, actually. I mean, this is what will happen most of the time with the AI adoption, and this is my assumption this will happen. So let's say that we have two hospitals, Hospital A, Hospital B, same patient, same condition, same patient, same condition, but ultimately we get different case, right? Because of the quality of the services, availability of the resources, availability of the healthcare providers, etc. I do believe next time what we will see with the AI solutions embedded in the healthcare, AI predictions will also be different in long term. Same patient data, but different AI predictions. And maybe you talked about this in other sessions as well. There are data biases, different reasons behind this. But one another thing that is very important, particularly for system level improvements, the AI predictions are not only about the patient, right? Work system elements share shape how predictions are used and the quality of care delivered, right? Because even if you make the right prediction, if nobody is following up, with the right intervention, right management, then the AI prediction will not really help you, with that prediction. And AI provides, let's say, the predictions, but the work system determines the impact. And this is exactly what we want. And that's the reason why, particularly in safety context, not only patient clinical conditions, but we also need to understand what are the system elements, right? Like the people, like organizational challenge, like there is a policy, there is a culture, as I mentioned, workflow design, and the equipment availability. So these are all driving the impact of AI. Not only AI, but any other technology that we can count here. Okay. And the third, but not last, uh, that is very important component, I believe, in future AI applications in healthcare particularly. Human AI collaboration. So how we can integrate AI in hospital, systems, and how we can really incorporate the human, not at the end as end users, but also but also substantial contributor to the AI development. So how many times we ask, physicians, nurses, what they think about the solutions, or how many times we really try to understand their needs and requirements, right? I mean, if you go talk to the physicians, most of the time, I mean, if you start the discussion with AI, they will say something else. All right. So this is not their problem most of the time. So we really need to understand what are the user needs and how we can capture their requirements for, workflow improvement or safety improvement in hospital settings. Okay. I think here one thing that is very important, like we need to understand what is the role of human, like wisdom and values, ethical oversight, judgment, and creativity. And the role of AI is in general with the pattern detection, prediction, and scalability, right? And if we can bring these two together, then we can really benefit from the AI solutions. And here we really need to understand that the users, end users, particularly like the patients, providers, really want to, have applications that make a difference, right? So this is our ultimate goal as well, like how we can have a quality of human AI decision making at the end. All right. And one main common expectation, of course, to make these collaborations successful, explainable AI. Again, the Professor Paco has extensive research in this field, and he is leading the way. You can read his paper, but we ultimately need to understand how this technology, will be read by the end users, right? I mean, how we explain the outcome to the physician because they don't want to just see the results of the prediction. Okay. And this ultimately have an intuition role, and this is how we can expect a better AI assisted decision making. Okay. So think about that. We bring all these three elements together. As I mentioned, the AI, safe AI governance, it was the first. Proactive risk management was the second, And the third element was human AI collaboration. And this is one recent study that I have with my research team that we've been trying to come up with a safe AI governance framework. And what we try to do here is really propose a five-pillar human-centered framework integrating ethics, data, risk, and agility. But one part that I really like you to pay attention is the following. So in each aspect here, I have one particular section called human in the loop role. Human in the loop role, human in the loop role, human in the loop role, and human in the loop role. I think throughout this whole process, we really need to understand the role of human. Okay, not again, this is a very common practice that's why I'm repeating myself, but we shouldn't go to the end user just once everything is ready. Instead, from the beginning of the process, we should go understand their needs, their requirements to make the system better and safer. Okay. So saying that, I mean, I have a few applications, in particularly these patient safety context. As I mentioned, most of my the main application area that I'm interested in is safety context. Like, I've been working with multiple hospitals, but these four examples are the ones that I'm really focusing on. With Cleveland Clinic Abu Dhabi, we've been having a couple of research on pressure injury prediction and management, collapse management. This is one type of bloodstream infection. With SSMC, Sheikh Shahmut Medical City, I have a couple of research projects: acute kidney injury prediction and prevention, and sepsis management. But one part that I really like you to pay attention, that I don't want to call it sepsis prediction, all right, or AKI prediction. So it is more about management. So we need to really come up with a, system like a management pipeline that will help the hospital to make prediction, then come up with the intervention, and ensure that they will have a better management system for a particular issue, either sepsis or AKI or HAPI or collapse. All right. And in a typical architecture, you see a typical application that we have. I am not going to talk to the physicians at the end. From the beginning, from the day one, day zero, I go and understand what are their needs, what are their requirements to make a difference or to make an improvement in the organization. Okay? So let's give one example. I don't want to scare you guys, with my slides, but just to give you a better context, what I'm working on, let me give you one idea and one challenge: sepsis. How many of you heard sepsis? Can you please raise your hand if you have ever heard sepsis? All right. I think from this day you will never forget it. Okay, hopefully. So what is sepsis? Sepsis itself is a medical condition caused by infection and the body's immune response, not directly by human error. I hope you never experience, or your relatives, your family. But what happens is you go for surgery, and during this surgery or post surgery, you might develop some infections. Mainly, this may start with your clinical condition, but one thing that is really important, and this really gets my attention, both human and system level factors can contribute to sepsis developing, worsening, or being recognized too late. All right. So let's say that because of your clinical conditions, you catch this kind of infection, but unfortunately, it is getting worsening, because of the delays in the process. And this is very important challenge for us. And some other issues, as I mentioned, delayed diagnosis of an infection, missed warning signs or poor communication between care teams, delays in giving antibiotic or foods, inadequate infection prevention practices, poorly designed workflows, staffing shortage, or lack of monitoring systems. So I hope you accept the, fact that, by only using patient clinical conditions, maybe you can predict patients who are more prone to sepsis, right? Maybe. But it will not really help you to understand these components, these examples, like whether there is any delay, there is a communication challenge, etc. So that's why I'm saying it is not just about the prediction, but also intervention to really benefit from the AI solutions. Okay. Let me share with you the magnitude of this issue in real practice. So it is a threat for public health, and it is also called the silent global killer. So in a year, almost 50 million cases happen, around the world. And now this number will really surprise you. 11 million deaths per year are caused by sepsis. That means 1 in 5 patients are actually dying because of sepsis worldwide. All right. Maybe you never heard it before, but most of the time, particularly for the death rate in hospitalization is caused by this particular infection. All right. Let me give you some numbers from different countries. Maybe you like to see one particular example from Spain. More people are dying because of sepsis than heart attack, breast cancer, colon cancer, pancreatic cancer. All right, so you can see that this is something that can be preventable actually, right? But since we are not proactive, since we are not preventive in the hospital, we delayed for XYZ reasons. Unfortunately, many people are dying in hospital settings. All right, you see the numbers, right? More people are dying in sepsis in Spain than heart attack, breast cancer, and some other types of cancers as well. Of course, as I mentioned at the beginning, it doesn't have only implication for the safety, but also it has a huge burden for the community, right? Because it really increased the hospitalization in the hospitals, meaning that patients are, making the hospital busy, right, with this during this infection to be fixed. Okay. Another question is how we can really make this process more proactive, more preventive, maybe using AI. Okay, AI could be one solution. So again, better if we understand the problem. And this is where I want to move you with me together. All right. So this is the beginning of the project. Imagine that, we try to understand why this sepsis is happening in hospitals. So let's start with understanding the current process first in the hospital setting. So what happens in a typical hospital setting? So we have this, the patients, particularly I'm talking about inpatient patients who are staying in hospital following their surgery, for example. They might go for triage, right? Like the nurse does the rounding in the early morning, checks, the patient conditions, etc. And in general, they log this information to patient electronic health record, right? And there is one early warning system record. In general, in all hospitals have this, and they activate code response. So let's say based on the patient clinical conditions, there is a highly likelihood that the patient is developing sepsis, then they activate the code, all right, in the electronic health record system. So this is the beginning. But then look at the whole process. You activate the code, then you expect the physician to do the examination, then ensure whether the sepsis is really the case. And if that is the real case, then we activate the code sepsis. And here is very important. When we activate the code sepsis, in general, the expectation is to apply the sepsis bundle intervention in 1 hour. And what we call this is golden hour. Because if there is any delay beyond this 1 hour, unfortunately, we lose the patient. All right. Either patient dies or patient lose some organs or some severe implications to the patient. But look at the time that we really, spend here, right? I mean, this is an average number in the literature. And I'll give you more, numbers for this part particularly. Okay. So let's move on. So we do all these exercises, and now we do the nurse rounding, the early warning system activation based on the patient clinical conditions, etc. All right, examination, with the and we expect the 1 hour bundle intervention in 1 hour. And the clock starts, right? There is 1 hour. But unfortunately, I mean, there is no hospital really achieving this. All right. So this is one challenge for you guys, like how we can have a successful bundle intervention, for example, in hospital settings when we identify that there is a sepsis, or you can give any other examples like hospital acquired infections as well. Okay. And hopefully, if we are lucky, if we achieve the goal of dealing with the patient, then we can assume that the patient will be monitored and hopefully discharged from the hospital as well. But what happens in this process is the main challenge. Again, maybe we can make a good prediction at the beginning, but then we need to understand how we will be able to fix the problem here in the process. Because the current system in hospitals, early warning systems, they do not have to be, AI driven, but there are a lot of false positive alerts. And because of all these numbers, because of these high rates, then the healthcare professionals, they are so busy, they start ignoring, the alarms. I don't know if you heard the term called alarm fatigue or technology fatigue. So nurses are a great example, physicians are a great example because always something pops up on their screen, right? Alarming, 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 so that they start ignoring it because they cannot deal with it, right? Particularly if they have a lot of false positives, etc., then they lose their trust to the system. And the question here is how we can really increase their trust. All right. But remember that we have to do everything in 1 hour. But let me show you what we found in the literature. And actually, none of the hospitals in the literature, at least in the research academic papers, none of the hospitals or none of the research studies showing that they can deal with this in less than 1 hour. All right. Most of the time, it takes a day to suspect a sepsis case, then come up with the intervention, providing the right medication. Even some instances, as you can see, it takes 2 days, 3 days, and particularly we lose the patients if it is really, really delayed. Okay. And one thing that we need to understand here, patients do not suddenly deteriorate. Healthcare professionals suddenly notice. Of course, here we don't really judge, people, but we really need to understand if we like to benefit from the technology, how we can ensure that the healthcare providers will also use it, utilize it in real practice. All right. So these are some of the gaps now we need to fix, right? Either with AI or without AI, like hard to diagnose, right? I mean, there is no clear reason behind sepsis as an infection. Okay, so it takes time to understand that the patient is really, really sepsis because it is type of an infection that you can assume that the patient has a fever, and most of the time it was mixed with pneumonia, or some other infection types, pneumonia or others. So we need to understand, this is also very difficult for healthcare providers. Or alert fatigue, as I mentioned, the rate of false positive alarms or late recognition. Now, considering all these challenges, on top of that, we have some challenge with the use of AI. We try to come up with a solution. All right. So our solution is called Sepsission. Like it is a mix of, you can imagine, a mix of health, providers like physicians, nurses, and AI models. And as I shared earlier, the story starts again with understanding the user needs and their requirements. Okay. So what we do here from the beginning, we consult with the healthcare providers like nurses, physicians to understand what are the variables or factors really determining or driving sepsis cases. But in the meantime, in parallel, we also work with AI, with the open data sets or the data set available in hospital settings to understand what is really driving the outcome. All right. So let's say that we find that the healthcare providers rank these 10, 15, 20 variables affecting the outcome, then we also validate it with the AI. And but AI, if AI solutions show that some of the factors that are not listed by human like the healthcare providers, like the smoking, cholesterol, etc., then we go back to the healthcare provider and validate, verify whether these are really important and why they missed it at the beginning. Okay, so from the beginning, rather than just working with the data set in an isolated area, we work with the healthcare providers. So my main collaborators are, in fact, physicians, nurses, and healthcare decision makers. So we try to understand what are their needs and requirements. Okay. And one another thing, as I mentioned, to really increase the explainability of the model, we try to come up with some visual tools that really help physicians or the end users to understand how we make this prediction, right? And I believe that the visual tools are really, really helpful in this case. And one tool that I really like, the method, as most of you know, is BBN, Bayesian Belief Network models, right? So these are typically probabilistic graphical models to represent uncertainty and causal relationships. All right. So the advantage is for the end user. I mean, we made it more user friendly, of course. I'm going to show it to really show how different factors, different variables affecting the outcome. So in this case, sepsis is the outcome, right? And we really benefit from the application of sepsis. I mean, in terms of reducing the false positive alarms, because in terms of accuracy as one of operation performance measures, it provided more accurate results, but also it is visual. And one another advantage here is we can also do some sensitivity analysis. So let's say there are some modifiable risk factors. Physicians can actually change one factor and see in real life how change in one variable, for example, creatinine level, will have an implication on the outcome, which is sepsis. All right. So these are some of the things that we provide in our decision support tools. And this is kind of a very short interface of the sepsician that I, introduce you. Again, as you can see, we provide the probability, right? But this is not the only thing that we provide. We provide some more guidance for the end user, like what they should understand. And some of the modifiable risk factors can be changed so they can really play with it and see how they can, help the patient in a timely manner. And we also provided some guidance. I think here is the key part in this, decision support framework. We are not just making a prediction, but we also come up with a management pipeline. So what is next? So if we believe that the patient is developing sepsis because it is 89%, there is a highly likely case for this patient to develop sepsis, then what is next? So what should be the antibiotic regimen, for example? All right. And there are different regimens available. We are also implementing the guidance, local guidance available to ensure that the intervention is also following the available guidance and policy in the hospital and the healthcare organizations. All right. And one another motivation that we try to achieve here is to really, as soon as we make the prediction, we initiate the golden hour as well. So we try to really achieve in the hospital whether we can come up with the sepsis bundle in a successful manner. All right. And if you are interested in this research, I mean, do let me know. I'm happy to, provide you the framework so you can have a look at it further. Okay. So saying that, the last part, as I mentioned in this interface, is the Bayesian model. So here is the part that the end users visually see how we came up with the prediction, and if there are any modifiable risk factors that they can change and see how this will have an implication on the final output, which is sepsis. All right. So the next thing that I really want to understand, since I find, great minds like you guys, if you have any good understanding, good solutions, this is my recent interest in my research. So what is the optimal ratio of human AI collaboration? So let's say that the system performance will be peak when we have the optimal human AI collaboration integration. But what really makes it this point or any other points, because this is a conceptual framework that we have in our paper now, what really makes or defines these, ideal case. All right, so this is what we need to understand, because certainly in healthcare, the feature of AI depends on the human integration in the process, because they are the end users. And healthcare is a socio-technical system, right? With full of a human integration in all aspects. So we really need to understand, that the system performance might be low if we use only human because of the cognitive overload, fatigue, right? It might be low again if we just use AI because of the automation bias, de-skilling, over-reliance to the AI. But the question is how we can ensure that there is a great integration or collaboration between human and AI. All right. Saying that if we implement all these sepsis, ideas together, so this is what we try to achieve actually. I mean, if we implement sepsation here, I mean, we call it, human AI decision support framework as well. We try to reduce the waiting time here totally because we are using the patient clinical conditions available in the electronic health record system, and we suspect the sepsis case as soon as possible, right? I mean, as you can see, suspected sepsis is identified here, maybe after, 10 hours, 15 hours, whatever. But now we are able to make this prediction as soon as possible. But now the challenge is really to improve this process. So the real, benefit of AI is actually not about the prediction. Again, this is what I would like to, emphasize here. How to integrate it throughout the management pipeline, management system. All right. And remember, every hour, delay in the treatment increase the mortality rate by another 8%. So even if you make one little reduction here with the waiting time, either here or here, then this might have a huge implication on the outcome. So please, I think most of you are interested in applying AI in real practice. So think about how your solutions will have an implication to the end users, right? Like the patients, like the healthcare providers. I think we should always put ourselves on the shoes of others, right? I mean, this is what we need to achieve. This is kind of a conclusion for the first part. The first idea is safe AI doesn't really mean the model performance is good, right? It demands system level governance, integrated risk, and alignment with real clinical outcomes. Trust is designed, not assumed. So we cannot assume that our model will be trusted, uh, providers, because believe me, healthcare is full of, the smartest people, most talented people, right? You need to convince them from the beginning, not at the end. And AI delivers value when it augments people within redesigned workflows for safer, smarter, and scalable care. So the main, conclusion that I would really, really put here and emphasize how we can better understand user needs and requirements in healthcare, either with AI or without AI. I think this is very critical question, and we need to understand the importance of empathy. So how a new technology, how your algorithm will be perceived by the other side, and in this case, it is patients, healthcare providers, healthcare decision makers. But I think the key word is really empathy, and we need to learn how we can, put ourselves on the shoes of others. Saying that I have one short video, then I'll try to summarize the ideas. I think we started a little bit late, right? If I'm not wrong, but I'm hoping to share this video, and then we will have one short, kind of a workshop, case study introduction. All right. right. No conflict of interest with the Cleveland Clinic, but I really like to emphasize here the role of human, right? I mean, as you can see, the healthcare as an industry is, human centered, right? I mean, the end users are human, either patients or providers. So always our solutions should consider this. Okay. And when it comes to AI, again, we need to understand how it will have an implication to the end users. Okay, then the next few minutes, unfortunately, I'm not there. I was hoping to be there, but I tried to update it to call it guided asynchronous workshop. So I'm just gonna give you one case study. You can consider it as a self-study or homework, or you can totally ignore it. I leave it to you. But think about a particular example that I give you, a problem, and how you can approach to this problem from a with a holistic view, like a system view. All right, so this is what I would like to do. Okay, in this example, we do not have sepsis. Let's forget about sepsis for a while. And I bring you a new problem, medication errors. And this is a very common problem again in hospitals. So I mentioned at the beginning, if you recall, the medical errors are the third leading cause of death following heart diseases and cancer. Okay. And one main type of medical error is medication error. All right. So let's see one scenario here. At a hospital in Dubai, an elderly patient is prescribed digoxin for heart failure. The intended dose is 125 micrograms once daily, but a tenfold dosing errors occur, and the patient receives 1.25 milligrams daily. The pharmacy dispenses it without flagging the dose, and the patient begins the regimen. Within days, the patient develops nausea, confusion, a dangerously slow heart rate. The symptoms are initially misattributed, and by the time the error is recognized, the digoxin toxicity has set in. Despite emergency care, the patient dies. And this is a very common scenario happening. Okay? An internal review uncovers system level failures. So imagine that you are part of the review process. Inadequate dose checks, poor electronic prescribing safeguards, and missed pharmacist intervention. The case highlights the urgent need for improved system design. You can imagine now the hospital has a system, and we are in fact trying to redesign the system, change the workflow to prevent these medication errors to be not repeated again and again. Okay, particularly in preventing similar high risk medication errors. So if I give you such a scenario, I know you are in this, summer school at Granada for learning AI, but think about the problem is improving the system design because of high medication errors. Here, intentionally, I put it in brackets, right? They're possibly using AI because AI is certainly one solution, certainly, but first we need to understand what is the problem, right? And to really, understand the analogy here, maybe you've heard this, the Maslow's hammer example. If the only tool you have is a hammer, it is tempting to treat everything as if it were a nail. Okay. Since this AI, I mean, it came to the picture now, everyone is thinking from the day one, how we can apply AI to X, how we can apply it to AI to Z, right? I mean, think about, whether really the AI is the very first solution. But what I would like you to think about is to identify system-wide factors behind medication errors, including processes, technology, organizational practices. Maybe certainly AI can help and develop actionable solutions that address the root causes of medication errors. Like, and the outcome that we are expecting very similar to the substitution example, whether we can come up with a decision support framework or what is our recommendation to the decision makers or the policy makers, whether they can improve the medication process, they can improve the electronic health record system. There are multiple opportunities to make an improvement, right? And I'm leaving it to you to think about how we can make an improvement. And I introduced you the system approach before, right? Like understanding the people, risk, system, and design perspective. And in fact, this comes from a toolkit that was developed at the University of Cambridge led by my PhD supervisor, Professor John Clarkson. And I really like to apply this in the workshops. If I was there, maybe right now this is what we would be doing with you guys. But think about, how we can approach this problem as a system thinker, right? Because what really makes a difference in, healthcare is to change the system, right? I mean, redesigning the process or the system to make a difference. I believe you guys are somewhere here right now, system awareness or system knowledge. Now you are learning a bit. And I'm hoping with more practice, you will have a better understanding of the system thinking or systems approach, which are the baseline fundamental ideas behind systems engineering major to have a better understanding on how we can solve this particular challenge. So we provide these canvas, in the workshops in general. Again, this is a synchronized exercise. You can do it later if you like. And if you like to share with me your findings, I'm more than happy to discuss with you further. But think about that you have such a canvas, and in each part, in each component here, you try to make one kind of improvement in your whole system. First, you start with understanding the scope, so this is an agreement, like describe the ambition for change and the boundary of the system of interest. And in this case, we try to improve the medication error, cases, right? Understand the context, define the problem, identify the stakeholders, develop the solution, collect the evidence, build a team, make the case, and manage the plan. But one thing that I really emphasize here, we dedicate most of our time to identify the problem. All right. And when I say identify the problem, what I mean is identifying the root causes of the problem. Okay. This is very important. And rather than spending most of our time for the solution space, we spend a lot of time for identifying the right problems. Okay. And think about in medication process, we have prescribing, maybe the challenges in the prescription process or dispensing, with the pharmacies or administering to patients. So you can focus on either each stage, or if you like to have a holistic approach, you can, see the whole system to be improved. Okay. And again, you see it is in bracket. Think about whether you can leverage AI or you can come up with some other solutions. But the starting point is not AI. This is what I try to emphasize here. We try to understand the user needs, and we really try to define what the problem is, what the root causes here is behind the medication errors. Okay. And this is the acknowledgement. I mean, you can reach out to this report as well if you like to use this toolkit in your future applications or any exercise, any assignment that you have. And the last slide, I mean, I would like to invite you all, if you are planning to come to Abu Dhabi or some of you are from this region, we have a conference, just 1 week before the ADIA Lab symposium. So if you are planning to come for that, you can come 1 week before, and you are very welcome to join us in this international conference as well. Saying that, I would like to conclude my session. Again, thank you very much, Professor Paco, for inviting me, and I'm happy to answer any questions students have. Thank you.
Thank you very much, by your interesting talk, Emre. I enjoyed. Please, the student people attending to the talk, question, just come here in this way. They can save and Emre can listen you. And watch.
Okay, great. Thank you very much for the talk, really enriching. I have a question that may be small detailed, but there is a point in the presentation where you show Bayesian probabilistic network, and you say that it's causality and it's more interpretable AI. My questions goes about how was that network created? It was done by an expert, like you went to a hospital and he told you these are the variables, these are the relations, or
Yeah.
they have been done through an algorithm for discovering from data?
Yeah. Thank you very much for this question. Actually, I always receive such questions, and this is one very important challenge with the application of BBN, like the Bayesian model or causal models, actually. I mean, in fact, this is what I can call is this is kind of a hybrid approach. So we first train the model with the data that we received from the hospital. I mean, first of all, we identified all important factors, variables, using the data set in the hospital. But then we validated with the healthcare providers whether they really believe that these variables are the main drivers of the outcome. In this example, it was sepsis. So I can call it like this is expert driven slash, the data driven model. But mainly it was driven by the data that we received from the hospital.
Okay, so thank you very much. Like my question was that if you were actually doing for the data, what is the validation taken? I guess it's talking with an expert and seeing the data and say, okay, this makes sense, this learning network, right?
Yeah. So of course, I mean, we check all the performance measures. I mean, by the way, Bayesian belief network was not the only, algorithm that we tried and tested. I mean, we tried all other traditional machine learning algorithms as well. But as far as I recall, that time, Bayesian belief network model was also one of the best in terms of, the accuracy performance. So what happens in that in that stage, when we do the, let's say, the data pre-processing and then the data training, etc. Again, we, go back to the end users, like the healthcare providers, to verify, these variables are really, really important. For example, some variables that we identified earlier, then we found that they are not really sepsis related, or they are not the cause of the sepsis. Okay. Or some variables, again, this is another topic, but we found that there is an endogeneity effect. I mean, I don't know if there are statisticians, you guys better know than me, but not only out, independent factors affecting sepsis, but sepsis may affect, some other factors as well. But ultimately, we try to pick the Bayesian model for a couple of reasons. The visual, contribution, so the end user can really see, the interaction between different factors affecting each other, and the sensitivity analysis. We also allow them to change one modifiable risk factor, and they can visually see how changing one variable has an impact on the outcome.
Okay, that solves my question. Thank you very much.
All right, thank you. Any other questions?
Thanks. Any comment? Any other question? No question?
I think everybody
No
wants to go
questions.
for lunch.
Thank you very much. We are just in the time for the lunch. Thank you very much. It was a pleasure to meet you online. I hope to meet you soon. And thank you for your interesting talk.
All right. Thank you very much, everyone. Thank you. Have a good day.